joining us today. My name is Will Smith and I'm the president of LiveSight, Liverpool Student Psychiatry Society, and a fourth-year student doctor at the University of Liverpool. A warm welcome to you all and welcome back to some of you for the 6th and final instalment of our series, How to Be an Anti-Racist Mental Health Researcher, where we ask what needs to change. Speaking tonight, we have Dr Sanah Ahsan, a liberation and community psychologist and poet, who will speak after her video, which we're sharing this evening. We have Dr Tarek Younis from the University of Middlesex, who will be exploring colour blindness and liberal racism in mental health. And finally, Jason Arday from the University of Durham, who will speak under the title We Matter as Well, Understanding Black and Minority Ethnic Mental Health in Education. We also invite reflections from Fazia Haider and Sandra Jayakody. We invite you all to join the discussion throughout with questions and comments, but I'd ask you to keep yourselves on mute throughout. If you would like to speak or ask a question for any of our speakers tonight related to the topics of mental health, research and race, then please write a comment in the chat. We kindly ask that you help us keep this an open platform, remaining on mute throughout the evening and refraining from using the raise hand feature if you want to ask a question. Questions this evening can only be asked by the chat function, which will be put to the speakers by myself. Just also to make you all aware, this evening's event is being recorded and live streamed on YouTube. The recording will be available to watch and share after the event is finished. You can also tweet during or after the event today with the hashtag #AntiracistMHResearch. If you're watching by the live stream and there's a question you would like to ask, you can either add a comment to YouTube or tweet your question with the hashtag and we will try to ask it for you. Please note that if you're watching via the live stream and you want to ask a question based on something you've heard this evening, there is a short time delay between the Zoom meeting and the live stream. Now I'd like to turn our attention over to our first guest this evening, and that's Dr Sanah Ahsan. Sanah, can you hear me there all right?
Yes, I can.
Hello. Let me just introduce Dr Asan to our audience. So Sanah Asan is a queer Muslim woman, an HCPC registered clinical psychologist, an award-winning poet, and all-round disruptor. Her work is centered on compassion, decolonizing understanding of mental health, and embracing each other's madness. You can read her full bio in the chat or on the Eventbrite page. Sanah, would you like me to share the video now?
Yeah, sure, that sounds good. Thank you.
Okay. So I'm going to share a video which was produced with Sanah, so just a moment while I get that up. Can you see that okay?
Yeah.
Okay.
This world will tell you to keep your distress in sealed letters of lips behind shiny white envelopes that no one need read. They will stamp it with a diagnosis, label your suffering an illness. They will call it depression, while you call it the natural effect of oppression. They will feed you pills to cure social ills, medicate injustice. They will name the imbalance of power in society a chemical imbalance in your brain. They will refuse to understand the causes of your pain. They will attempt to colonize the earth of your mind with language your mother tongue cannot swallow, and you will be lost in translation, searching for Urdu subtitles so that your grandmother might understand. As they offer terms like anxiety disorder and post-traumatic stress disorder, and you will wonder what this apparently ordered way of living is. A filing away of feelings into categories of cabinets that cannot be contained. But you must remember that this feeling is not a sickness. But you must remember that they once called homosexuality an illness of the mind. Remember that there was a time that they once labelled runaway slaves as mentally ill for desiring freedom. Remember that they still deem psychosis as a black disease. So please remember and keep feeling. Keep feeling. Cry on the tube in front of passing strangers. Wear the cuts on your thighs like beautifully inked tattoos. Put your sadness on like it is the silkiest shirt in your wardrobe. Two-step with the grief anchored to your feet like they're your freshest pair of Air Force Ones. So let your tears fall in protest. Release your rage in revolution to a world that is terrified of unfiltered and unedited truth. Do not dilute your heart. Gather community around the table so you can feast in this feeling. Let their sorrow and joy be a convoy to ride together out of this societal warfare. Show them that your tenderness packs muscle, that this tenderness is shared, that this suffering is to be understood at the collective, not only the individual perspective. There is healing to be found in our community. Phenomenal woman, I am in love with your tenderness. I am in love with our tenderness. So please, stay tender. Stay tender.
Sana, that's a really brilliant and such a powerful video. I'll hand over to you now.
Thank you so much. I just want to apologize to you all first, because I'm so sorry that I can't have my camera on today. I've got really bad inflammation in my eyes and they're super red. And it also means that I'm not able to do the full presentation that I was hoping to do, which I don't know if some of you saw was entitled, "Is Research One of the Master's Tools?" But what I will do instead is just do a bit of a fast forward, cover it, like just talk through really the key points of what I was hoping to talk about, just the top headlines. And yeah, I'm still grateful to share space with you. So thank you so much for having me. Yeah, so the reason why I wanted to start with a poem really is just as a device to point you towards the incredible poet Audre Lorde's seminal essay, "The Master's Tools Will Never Dismantle the Master's House." And in this case, I'm thinking about the Master's House very much as systemic whiteness. And for me, poetry, I don't see as one of those tools. I think poetry is a device to disrupt systems of whiteness. And we can use it as a means to actually author and learn about Black and brown life outside of what is scholared or deemed legitimate, deemed as legitimate knowledge in academia. But I think the question that I really want to ask you all today is just thinking about, is research one of the master's tools that actually uphold the master's house of systemic whiteness? I'll just give, when I'm speaking about whiteness, I'm thinking really about this deeply embedded discourses, values, systems that uphold a false hierarchy benefiting those socially racialized as white and repeatedly disadvantaging people of a global majority. And I use the language people of a global majority instead of maybe, BME, because I think some of these other terms center whiteness by default. But I wanted to spend a bit of time initially when I was going to do the whole presentation to think about the different ways that I believe, as it stands, research does serve as one of the master's tools to uphold the lie of whiteness. I won't go into all of them today, but just, a couple of examples. I mean, historically, this tool has very much upheld the harmful lie of eugenics. We're still using, for example, the ANOVA as a statistical method, especially in psychology, we use it massively all the time. And Fisher and Pearson, who created the ANOVA, were proponents of eugenics. There's lots of different ways. I mean, I'm not sure if this is I'm assuming that this might have come up before, but maybe not for everybody, that we know that the current research populations that are used are 95% with weird participants, which is Western, educated, industrialized, rich and democratic participants, right? And psychological research especially this research is often being conducted by white researchers. And I think this feeds the narrative and the lie of psychology often as a science, because all of this is feeding this idea that we are an evidence-based profession. And I think this can be quite a harmful lie, but I'm just moving on to thinking about often how when we are looking at issues of race within research, the focus is often on those who are harmed by systemic processes rather than those who actually benefit from it. And I wanted to just point you towards my research, which was holding up the mirror on whiteness in clinical psychology, really actually trying to consciously shift that lens towards those who are benefiting from systemic whiteness. And I think it does say something that this research was the first in UK clinical psychology to look at systemic whiteness from the perspective of the majority group, so white middle-class female psychologists. I only published it at the end of last year, and I think things are shifting now, but we're not actually looking at whiteness from the perspective of those who benefit from it. And just in reference, I think, to the poem earlier as well, I think research can be a tool to often actually legitimize Eurocentric and Western knowledges, right? So a lot of our research at the moment is really reaffirming this very medicalized and individualized understanding of distress. Like, we've got still loads of papers coming out that are like, mental illness is on the rise in COVID-19. And I think this language of illness, of disorder, it really obscures us from the structural injustice that is causing our suffering. It turns us away from that. And I think this is how this tool can uphold these lies of whiteness. So yeah, I wanted to ask the question, is there a way that we can use this tool to liberate people of a global majority, to liberate us into a fuller humanity? I mean, I believe that we can use it in a way towards liberation if we think about it as storytelling. Whose stories are we telling? Who is telling those stories, and are these stories accessible for the people that they're about? And how are these stories actually reaching the people that they're meant for? Can we use the arts? Can we use media differently as part of this storytelling? And I think fundamentally, the current system that we have for research is very much like, gatekeepers around it. We've got this peer review process about, who decides what gets published. And often it's in incredibly inaccessible language. It's very, very hard to actually make sense of a lot of the research papers that are out there at the moment. And I think what we need to be asking in terms of this peer review process is actually, when we're deciding what gets published, asking the question, is this research committed to the liberation of a fuller humanity? And is this research actually committed to undoing the lies of systemic whiteness? I think this needs to be the question that we're asking when we're thinking about things like, instead of things like validity and rigor and all of these things. I think this is the most important question, But again, we're still, the whole question, the big question is always, revolution versus reform. Is there more we can be doing outside of these tools too? What can we be doing outside of research to actually think of mediums that might not be the master's tools, and for me, just bringing it back to poetry is one of those, or maybe ways that we can integrate that into the models that we're using at the moment. So yeah, I mean, that was my quick fire summary version of what I was originally intending to do, and I just want to apologize to you all again. I'm so sorry that I can't see you guys face to face, but thank you so much for having me.
Sanah, thank you very much for coming along and for sharing those words with us and those thoughts. It was really useful to hear just what you were going to say, and yeah, some brilliant points you've raised there. And thank you very much, and thank you for allowing us to share your video as well, which was brilliant. Thank you again, Sanah. I know you have to leave now, so we were to ask any questions, but thank you very much again for coming along. And next, I would like to turn our attention to the second speaker for this evening, which is Dr. Tarek Younis. Tarek, are you there?
Yes, I am.
Hello, I might just introduce you to everybody. So this is Dr. Tarek Younis. He's a lecturer in psychology at Middlesex University. He researches and writes on Islamophobia, racism in mental health, and the securitization of clinical settings. He teaches on the impact of culture, religion, and globalization on mental health. The full bio for Dr. Younis is in the chat and is on our Eventbrite page. Tarek, over to you.
Okay, well, first of all, thank you so much for having me. I'm really inspired by Sanah's work, so I'm glad to be following up right after her. First of all, just to make sure, are you watching the actual presentation, or are you seeing the presenter mode on the full screen?
I think we've got the presenter mode there. Yeah,
you got
so
the presenter
I think we
mode?
can
Okay,
see, yeah.
Okay, now that's better, right?
That's perfect. Yeah, thank you.
Perfect. Okay, great. So I'll just go ahead and start. So again, thank you so much for having me. I apologize. There's going to be a lot of screaming in the background. That's absolutely normal where I am. So please forgive me for that. At the same time, my thoughts are going to be slightly disjointed. I've been writing about many of these themes over the years. And what I'm going to try to do right now is sort of collect or I guess a number of themes together and try to demonstrate sort of the link of thinking about racism, politics, and sort of the role of mental health research in the neoliberal era. And the three themes I'm going to be talking about is racialization, colorblindness, and sort of politics in mental health as a whole. You know, I do apologize if you've heard any of this before, but I hope to be able to offer just maybe another sort of refresher or a different perspective on things. I think for me, it's always just important to begin when we're talking about racism, to sort of distinguish between the sort of illiberal racisms, the racisms that we all sort of see and acknowledge, you know, that sort of hostile, wholesale hostility towards, you know, towards entire groups, whatever it might be, Muslims, etc., you know, or immigrants, you know, just a wholesale demonization. That's the sort of illiberal racism that I think most people can acknowledge, and most people often are referring to when they think about racism. But one of the things I'm going to be really talking about why it's so important for mental health research are the liberal forms of racism. A great book called Reactionary Democracy just came out that talks about this. And it's sort of, liberal racism operates on registers of good and bad, you know, the good minority, the good migrant, you know, the good Muslim. But in doing that, it reifies this dichotomy between the good and the bad. And this is actually far more significant in what we call sort of the post-racial era that we live in. The post-racial era can be understood as a way whereby, you know, sort of systemic racism or societal racism has been addressed. Right now, the type of racism that we see are often just coming from the margins of society, which, you know, is highly questionable in the first place, but lends itself to this narrative that racism is an issue of the past. To this, in a post-racial era, there is the concept of colorblindness. And this is really, really important. I need everyone to sort of hold on to this. Colorblindness comes in when issues that are racialized are the racialized signifier in it is either erased or abstracted. And one of the ways I'm going to talk about this is that mental health is ideal in the 21st century to contribute to a post-racial era. The example I often give right now, just very quickly to think about liberal racism, was one that's shared with me, and I think it's published in a book right now called Cut from the Same Cloth. It was about a Muslim woman who went to seek therapy here in the UK. She wears a face veil, and the therapist told her that one of the signs for successful treatment will be her ability to take off her face veil. And what I want you to hold on to this in this example is that this therapist, he said that with the best of intentions, right? He said it with a smile. I'm trying to help you. I'm trying to sort of liberate you, so to speak. And I'm going to try to sort of make sense of this, especially when it comes to racialization. But first of all, I think often we talk about race, we talk about racism without really maybe presenting what we might mean by it. For me, racism comes from the fact that groups are racialized according to dominant ideologies and particular social conflicts. Dominant ideologies being like nationalism, social conflicts being like the war on drugs, the war on terror. And so we all sort of are part of a racial social system like nationalism. That's what Vanilla Silva and Paul Gilroy have written about. And therefore, there's negative and positive performances or negative and positive experiences of being racialized. An example that comes to me was a Muslim psychiatrist here in the UK. She spoke out against the prevent policy, which I'll get to. And she got in a lot of trouble in the NHS for sharing her thoughts. And the other Muslim psychiatrists came to her after, and whereas most racialized white staff came to her and offered support of solidarity, the Muslim psychiatrist came to her and said, "Why did you rock the boat?" And here we can sort of see the wisdom of Frantz Fanon if we think about sort of, the colonized mind, so to speak. But the whole point here is that I think mental health research hasn't very much tapped into these sort of positive performances when it comes to experiences of racialization. But all of this is to say that racism is not simply this virus or this fringe hatred or psychologized prejudice. It's something that distinctly serves power. It serves a purpose. As it comes to Islamophobia in particular, if we think about Stuart Hall's, the fact that racism is a floating signifier, we understand thinking a little bit more and deeper into how Muslims are racialized. How is it that Muslims are picked out on the street according to certain behaviors, according to certain performances, just by appearing non-white? We can see the various trajectories of where these signifiers come from. The one that I think I'm just going to emphasize right now, just to bring in an element of intersectionality, is the one about nationalism. And we know nationalism is on the increase in the global north. This is something none of us as mental health professionals can deny. And it's through nationalism, or what would be construed as ethno-nationalism. Nationalism in and of itself construes the population as homogeneous. So it's one that sort of the public imaginary sees itself as a white public imaginary, and therefore anyone who's sort of non-white is sort of already on the margins, is already on the outside. There's a particular history to that. But the reason why that signifier is so important right now for this discussion is thinking about how both racialized Muslims and, let's say, racialized Black individuals are also, they are both racialized in nationalism as non-white, so according to the exact same logic. And I think there's obviously distinctions then if we go to the various other sort of historical trajectories. We think about imperialism and Orientalism, hijab, niqab, that's what the psychiatrist was talking about, that came from the war on terror logic, that this idea that we need to liberate Muslim women from their repressive culture. So obviously there's distinct histories and ways of understanding where signifiers come from. We talk about Muslimness and Blackness, but nationalism is very interesting because it's one that affects both Blackness and Muslimness combined, and it's something that I'm going to get to in a second. Which brings me to color blindness. I talk a lot about color blindness, and you can see it a little bit more in my writing. The thing that I think is very significant for mental health researchers when they think, or mental health in general, thinking about racism right now, is how issues that are racialized. So I'm going to go ahead and just make the statement that the war on terror is a racialized project, just as it is the war on crime, etc. We know, from statistics, we know just from the wealth of research that exists. But if you look at prevent training, prevent, for anyone who doesn't know, is a public duty upon NHS staff, including mental health professionals, to have due regard in identifying and reporting individuals they suspect might be radicalized in the future, might become terrorists in the future, i.e. they're pre-criminals in the present. And the way prevent training operates is that it relies heavily on psychologization. And one thing it does is that in sort of trying to avoid the commonsensical association that we know very well in research. So we know that the public readily associates threat to the nation with Muslimness, with Muslim signifiers, be it appearance, be it behaviors, whatever it might be. Prevent training avoids all that, and it's able to avoid it. It's able to render it colorblind through psychology talk, through a sort of Eurocentric construction of psychological vulnerability, as you can see in one of the slides here in Prevent Training. This is just one of many. You know, it thinks about, the sort of feelings that people have. It felt exciting and made me feel special. I felt better about myself. I felt like I had a purpose in my life. And the point here is that if any of us, myself or anyone listening in, has these sort of psychological vulnerabilities, then we're all equally susceptible, according to our shared human configuration, we're all equally susceptible to the virus of extremism, the virus of terrorism. Now, of course, I'm not going to spend too much time into this. What it's very easy to discern is that the war on terror, because it remains a racialized conflict, or a racist conflict in this sense, it becomes quite apparent what sort of viruses are we talking about. In one of the NHS documents, the following are examples of grievances, which may play an important part in the early indoctrination of vulnerable individuals in the acceptance of radical views, a misconception and or rejection of UK foreign policy, which is a highly racialized point, distrust of Western media reporting. There we see sort of the West versus the rest, again, very racialized. And finally, perceptions that UK government policy is discriminatory, i.e. counter-terrorist legislation. That's, that's just sort of the cherry on top in terms of the racist rhetoric. And this is something you could find in the NHS right now. This is something that mental health professionals have to abide by right now, which lends itself to a report we just published a few weeks ago with MedAct. So MedAct published, and I was a co-author, on racism, mental health, and pre-crime policing, where we found through sort of a statistical analysis that racialized Muslims are at least 23 times more likely to be referred to mental health hubs. Now, this is a huge project that's being rolled out right now in the UK, mental health hubs across the UK for individuals who are suspected to be pre-criminals, individuals that might become terrorists in the future. It is probably one of the most egregious sort of, I guess, phenomena of racism that and mental health that I never thought I would see in my life. But it's happening right now as we speak. And, I'm not going to go into too many details right now. You can read the report. But, there's some interesting things about the sort of the psychologization then of individuals of individuals who we suspect might have political views we disagree with. And in one of the mental health hubs, they were doing a mental health assessment for anyone they suspected to be potentially a pre-criminal. Which has huge sort of ethical questions, which I think in mental health research is very significant. But we see here sort of emotional and behavioral dysfunction is one of the highest diagnoses, which is not really a diagnosis, it's just a way of psychologizing issues. And there's so much room for mental health research here. But again, it lends itself to this point of colorblindness, because now we're just really talking about mental health diagnoses. We have erased the actual subjects from the police who've written these reports. So all these reports are coming through freedom of information requests. They're erasing the actual subjects themselves. So just people who are here at a tourist site, someone's acting odd, is caught by the police and is sent for mental health support. There's some very questionable cases that the police themselves are presenting. But I want to bring in now sort of the intersectional dimension, which I found was really important. It hasn't been highlighted because I think one of the things that ends up happening when we talk about race and racism is that we tend to reify very distinct groupings between, let's say, Blackness, Muslimness, etc. But that intersectional dimension really signifies the racialization of ethno-nationalism. So it's actually flipping racism on its head. It's not about the particular groups. It's the fact that nationalism in and of itself privileges whiteness, and therefore in and of itself, it racialized everyone who's non-white. And one thing I found really significant here that I'm sort of sharing right now for the first time from the Freedom of Information request, if we look at the amount of Black youth who've been referred, it was 56 in one hub, which is 20% for potential extremism. And if you try to sort of deductive reasoning, you're trying to map where Black youth might fit among the sort of presenting ideologies, there's really none that really come to mind outside of potentially, outside of the colorblind, chaotic, threats, explosive, unknown. Muslims are most likely the largest proportion there, but also among Muslim extremists. And here comes this very unique sort of intersectional role between being racialized as Black and racialized as Muslim at the same time. And we've yet in mental health research to really, really capture that. I just want to highlight one example. I had to review an article, I think it was following George Floyd. I think there were several white middle-class psychologists who wanted to write about the significance of racism in mental health research. And so they wanted to write about racism more broadly. But you know, they focus, and I think legitimately, obviously, following the egregious killing of George Floyd, they focus on Blackness. But I was mentioning to them, if you're thinking about racism more broadly, you could think about how you know migrants are racialized, Muslims are racialized. You can think about almost all the sort of racialization as a whole, and they're like, no, we just want to focus on Blackness. But I think besides sort of maybe whatever that's going on in them that can be further elaborated on, I think in a way they're doing a disservice to the fact that Black Muslims might exist, and they sort of exist at the intersection of, let's say, the war on crime, the war on terror, the war on drugs. And there's something here that I think research has really done a terrible job of capturing. Which brings me sort of to racism, politics, and mental health as a whole. You know, I think there's a lot about what I was talking about before in terms of securitization. You know, these are all symptoms of wider sort of the political climate, so to speak. And I think the biggest example to me of this, in terms of the importance of the neoliberal era that we're in, you know, was the Grenfell Tower, whereby, you know, plus 70 people were killed egregiously again. But in The Guardian, it was posted that the Grenfell Tower mental health response was the largest of its kind in Europe, where more than 1,300 people were seen for PTSD and health reasons after the fire. Whereas now, following the Grenfell, sort of the incident, you know, there's so much more to elaborate on here, but we know now so much more of the sort of racist failures which occurred, the racist causes which occurred obviously prior to the event, but also following after it, the housing, the temporary housing, so many things, right? But there's a narrative to mental health response, to this idea of the benevolence of mental health response, but that also belongs within the neoliberal era, whereby, you know, mental health obviously designates a way of showing that the government potentially is doing something, that is taking things seriously, even if it's not what the people actually need. But also towards a wider sort of neoliberal ideals of things like resilience, etc. So cultivating that individual responsibility that a person can, you know, sort of take care of themselves. That was one thing. The second thing is sort of relating a little bit more, again, to this idea that mental health is also positioned. So Ian Parker has written a lot about this, but, you know, there's an idea that mental health research is sort of seen as this apolitical process. But we know is highly politicized. Every issue that's important in mental health is a political maneuver. There's a political maneuver in every decision that's made, even if, I'm forgetting the scholar's name now, he wrote Constructing the Self-Constructing America. He makes a fabulous point about how even just assuming a non-political position, assuming just something about the status quo, is itself one of the, you know, form and functions of how mental health professionals operate. But it in and of itself reifies, it reproduces the status quo of the sort of the political climate that we're in. You know, Jonathan Metzl in Protest Psychosis, he talks about how Black men So he talked about how some white psychiatrists in the 60s wrote about how Black men developed hostile and aggressive feelings, delusional anti-whiteness after listening to words of Malcolm X joining Black Muslims. According to the authors, the men required psychiatric treatment because their symptoms threaten not only their own sanity, but the social order of white America. And there's an element of social order that in and of itself will always be racialized, because the nation state itself is a racialized project. Now, there's so much here that I think we as mental health professionals and mental health research has yet to really just sort of tap into in terms of understanding. There's an element of coercion as well. This is a really important, but I think I'm going to leave this perhaps to a question if anybody wants to talk to me more about coercion. But I think I'll just mention a point of data sharing and surveillance, which I think is really important moving forward in what I've been seeing when it comes to mental health research. You know, one example here is a Home Office used a suicidal girl's admissions that she did to a psychiatric nurse. They used those admissions to claim that the family were lying about their right to asylum in the UK. So there's huge questions here of, you know, we've reified the therapeutic space as one being within four walls, but these walls are actually incredibly thin, and they're growing thinner and thinner. And I think, again, in mental health research, we've yet to really sort of capture the thinness of these walls, the sort of the digital moment that we're in when it comes to data sharing, surveillance, and how that, and the racialized repercussions of this. So I know I'm out of time. This was supposed to be sort of a summary, whereby I think there's a lot in mental health research that talks about more investment in mental health. You know, I'm sort of proposing a more understanding of racialization, which sort of brings in all these intersecting elements of how we're all racialized according to like ideologies like nationalism, the negative and positive forms of embodied racialization, more awareness to how side disciplines play a role in color blindness, and more critical reflection on neoliberal investment in mental health to the exclusion of other realities. So thank you very much.
Tarek, thank you very much. Some brilliant points you've raised there. Certainly really, really important critical comments you've made there as well. And certainly a lot of response in the chat there as well to what you've said. If you do have a question for Tarek based on any of the points he's just raised in that presentation, do feel free to write those in the chat box, and we will try and pass those over to you in our Q&A session, Tarek. But thank you very much. Next, I'm going to hand over to our third speaker, Dr. Jason Arday. Jason, are you there?
Yeah.
Hello. Hi, Jason. Let me just introduce you to everybody. So this is Dr. Jason Arday. He's an associate professor in sociology at Durham University in the Department of Sociology and the Department Executive Dean for People and Culture in the Faculty of Social Science and Health. He's a visiting research fellow at the Ohio State University in the Office of Diversity and Inclusion. You can read Jason's full bio in the chat or on the Eventbrite page. Over to you, Jason.
Thank you so much, Will. I really appreciate that. And it's a privilege to be here, and particularly to follow Sanah, the brilliant Sanah and the brilliant Tarek. So I'm going to hopefully not bring the standard down with some luck. But I guess what's really interesting is kind of dovetailing off what both excellent speakers have said, is the kind of context that we're living in terms of the kind of, I guess, the pervasive the centrality of whiteness and how it infuses in everything we do. In this particular case, you know, psychology and, you know, the idea of mental health interventions. And one of the things that I kind of want to really focus today about is really thinking about, I guess you could make an argument, society's most significant institution, education, and the impact of mental health within this context. Now, one of the things that's happened in recent years is, you know, the stigmatization around altered mental state it's come to the fore, and there's an acceptance now of how people encounter mental health, and, you know, hearts and minds have been opened in relation to understanding how these impact certain people. And when I say certain people, I guess I'm talking about a dominant white demographic. So, and it's interesting. So it's interesting to see what types of mental health are prioritized, and how, as Sanah mentioned earlier on, what types of mental health we deem to be deviant. And when we talk about Black and minority ethnic people, there's a deviance that underpins and layers the language of the Black mental health experience. Now, I suppose what I kind of want to talk about today are kind of two points that I believe kind of are synonymous with one another. So I want to talk about the impact of mental health on Black and ethnic minority people in higher education, particularly students and staff. And I guess the first point that I would like to make is that historically, one thing that's been prioritized quite significantly, generally speaking, is the mental health of white people. Now, the reason why I say this is because we can, I guess, the retort that I've had often when I've spoken about this in my research is that within the UK context, based on the 2011 census, we only have 14% Black and ethnic minority people, 4% being Black. So, of course, the priority would be there. But what Tarek has kind of beautifully articulated is how we reshift the paradigm of narrative. Now, when we move this away from a dominant white Eurocentric psychological model and not recognize that as the kind of MO for all people who experience particular forms of psychosis or altered mental state, we then begin to realize actually Black and ethnic minority people experience mental health in a completely different way, and it's predicated by the racism that they face. Now, within higher education, what my research has kind of hopefully illuminated is that Black and ethnic minority people, so particularly students upon arriving to university, come with a lot of intergenerational trauma, and they are occupying these spaces, having negotiated this intergenerational trauma and living through this trauma in terms of having to navigate the landmines of racism within what is perceived to be a multi-ethnic society. But we know within our legislations and our rejection of ethnic minority people within the UK that this isn't always the case. And very often when students come into those spaces, even in areas that are perceived to be culturally diverse, there's still this sense of isolation. There's still this sense of marginalization. There's still this sense of dehumanization. And perhaps really disappointingly, that is compounded or exacerbated by engaging with mental health professionals that often subvert these experiences or gaslight students into believing that the issue may not be race. There may be other external factors which really prey on this idea of a lack of resilience or potentially being hypersensitive. Now, for Black and ethnic minority people, when we think about the kind of instruments that are used historically to support Black and ethnic minority people upon presentation of mental health issues, very often medication is the first point of call. There isn't any engagement with behavioral therapies, desensitive eye movement therapies, or other holistic therapies that tend to be used with white people. And this was kind of a really telling part of my research. And I suppose to give kind of a background context, my younger brother's a psychologist, my mother's a psychologist, and I trained as a psychologist 2 years ago. So, in terms of learning about this, a lot of it is new, but what isn't new is the idea that actually we're seeing how these spaces have become more and more violent, systemically violent over the last 10 to 20 years. And just to draw on kind of some of the points that Tarek made, when we think of Islamophobia, if we're being honest, it's the most accepted form of racism. It pervades with absolute fluidity. Yet, a lot of the students that we interviewed as part of this, when they spoke about their experience of racialization, particularly Islamophobia, and they went and presented these issues, one of the things that became apparent to them was this questioning of their faith and getting them to kind of this feeling that, well, don't you think that some of the things that said in the news may be true? Now, as psychologists or helping in a pastoral capacity or in a counselling capacity, that shouldn't even be happening. Now, the regularity of these stories was quite interesting. You know, it was this kind of idea, and you know, I had students talking about this idea of, I was told that I need to be careful not to play the race card, and it could become a self-fulfilling prophecy, and that I need to take charge of my own destiny and not let race underpin that. Now, you know, we can all see the kind of the uncomfortability that presents with a white psychologist, a white middle class psychologist, saying that to a black student. And this is the problem. So there isn't actually mechanisms in place. And when we think about staff in higher education, it's a really difficult it's a very difficult context when we think about how, you know, oppressive this is, and how the violence that kind of ensues with this. And what it actually becomes is that you go from graduating from being a student dealing with these issues to then graduating to how to learn to survive. You end up learning these weapons, these tools of survival. So there are no mechanisms for you to utilize your mental health, to explore or to be supported through altered mental state, because actually there is that intergenerational distrust of mental health services for the reasons that I've explained. You go into these spaces in university that are aimed to support people, and what we find is kind of effectively a sea of whiteness in terms of psychologists. And I know that 90%, there's only 3% of psychologists that kind of reside from the Black and ethnic minority populace. But one of the things that we do need to think about is how we make mental health professionals culturally cognizant, how we make them racially literate, and how we decenter Western forms of psychology and Western forms of mental health engagement for something that is more applicable to the experiences that people have encountered. Now, without kind of, you know, garnering a victim status, Black and ethnic minority people live a life of violence. And when I say live a life of violence, this is predicated and it's kind of cocooned within a wall of whiteness. So every time Black and ethnic minority people enter these spaces, it's that whole death by 1,000 cuts. They're encountering continuous microaggressions, one after the other, which kind of leave these gaping wounds and lacerations, which are quite hard to hem in terms of the metaphoric loss of blood that happens every time you find yourself in these spaces. And I suppose what's kind of really powerful is that for a lot of the staff that I actually interviewed, one of the things that they mentioned was, you know, culturally, there are expectations of me to be really strong and to not concede with this, because generations before me encountered more. Now, the difference with generations before is that in that context, you could almost trace the contours of racism, because racism was this really overt tool that we were all able to witness in full flight. But because of our natural gravitation towards these overt forms of racism, what we don't actually acknowledge is how these covert, more insidious forms of racism impact greatly upon this generation experiencing this. And the problem with trying to trace the contours of that, it's very difficult. It's very difficult to explain to someone what you're experiencing without fear of judgment, further stigmatization, or having your altered mental state weaponized against you, which is what a lot of Black and ethnic minority people face. And we know that through the judicial system. We've just seen some of the statistics that Tarek has brought up in his own research in terms of how the judicial system and how our criminal system actually compounds the experience of Black and ethnic minority people experiencing mental health issues, even though they haven't committed any kind of criminality or engaged in any kind of deviance in the first place. So when you're working from that premise, it makes it really, really difficult. And I suppose one of the things that's kind of really telling, and I'm just mindful of the time as well, is, as we all do, I love music. And one of the second paper I wrote around mental health was really, the title of it kind of came from a song which a person who I was interviewing at the time who knew me was talking about. And what they kind of said was, they said, Jason, I know you like music. So I was like, yeah. They was like, I know you like REM. So I was like, yeah, I do like REM. And they said, do you know the song, the bridge bit in the song Imitation of Life? I said, yeah, I do. And so for those of you that don't know, it says, this sugarcane, this lemonade, this hurricane, I'm not afraid. Come on, no one can see me cry. This lightning storm, this tidal wave, this avalanche, I'm not afraid. Come on, no one can see me cry. And what was really powerful about that person saying that to me was they caveated that by saying, every day I have to apply my makeup twice. And so I said to them, what do you mean? They're like, I go into work, I encounter these racialized microaggressions, these violent forms of racism. I go into a toilet, I cry, no one can see me cry. And it's this tidal wave of microaggressions. It's this tidal wave of systemic and racialized violence. I'm afraid to go to my line manager. I'm afraid to go and get pastoral support and help. I'm afraid to get psychological intervention because I know that these will all be weaponized against me and it will compound what I'm feeling. And so in the end, I go into a toilet, I cry for 20 minutes, my makeup all comes off and I reapply it. And I do it where no one can see me cry and I face the world again. Now, that was a really powerful thing for me because hearing this woman of color speak about this kind of reapplication of makeup twice, because at some stage in the day, they know they're going to face these systemic violent aggressions, was a really kind of powerful thing. And it stuck with me. It stuck with me a lot because, you know, I use music as an out for anything, but on this particular occasion, you know, it was really powerful. And then she kind of said, like, to be honest, Jason, like, you know, and that there was a point where, you know, you're in that moment where if you don't laugh, you'll cry. And in the joviality in which she engaged with, there was tears in her eyes. She said, you know, I know you like Block Party. It's like eating glass. And I said to her, yeah, I can imagine. I can imagine. And at that moment, it made me realize how Black and ethnic minority men encounter mental health. And this is not to subvert their experience. It's very different when we map that across the intersection of what women of color encounter in terms of these mental health spaces, because there is actually an adultification of Black and ethnic minority women, which really positions them as being, you know, resilient, robust, and combative from a very young age. So when they go into adulthood and they exhibit any form of vulnerability, it's seen as a weakness, and everybody judges that as a weakness. And that is kind of really powerful. And when we kind of think about our mental health interventions going forward, you know, the point I would like to finish on is how we decenter a very Eurocentric, white Eurocentric form of mental health intervention, psychology, processes, and how we move towards something slightly different. You know, in David Harewood's documentary 18 months ago, Me and My Psychosis, he candidly talks about being sedated. And what one of the physicians said to him was they had records for how much he was sedated. They said what was given to him would be enough to tranquilize or to stun a horse. Now, if you think about how inhumanely David Harewood was treated in his greatest moment of need, that is the reference point for people of color. And that is why they don't engage with mental health services, particularly within the UK, because there is that fear of that, you know. And in a lot of the research and a lot of the people I've spoken to around mental health, most of the Black and ethnic minority people I know experiencing altered mental state have not declared it officially, and they're dealing with it themselves. And that kind of tells the tale. So I don't want to kind of end on a really dour note. I just think that it's a call to arms for all of us to think about how we reimagine kind of mental health, particularly because racism and the contours of it are harder to trace. And for us to remain agile to this, we do need to think about the forms of emancipation, and psychological kind of intervention that we engage in. The idea is to emancipate people to be able to express themselves in their best form. And I think at the moment, Black and ethnic minority people are not given the opportunity to do that. They're kind of, we want people to thrive, not survive. And I think for a lot of Black and ethnic minority people, they're always in this constant state and flux of survival. I just want to say it's been an absolute privilege following Sanah and Tarek, and having followed both their work extensively, this, you get to do some pretty cool things where this is an absolutely amazing buzz. So thank you so much. And Vanessa, thank you for putting this on. And Jessica and Will, I'm really grateful, and I really appreciate it. And yeah, let's keep the show going. Thank you.
Brilliant, Jason. Thank you so much. So great to have you here, and thank you for boldly speaking what it seems like so many people are feeling and have experienced, and are agreeing with the things that you've talked about, and raising those points so well. Thank you so much, Jason, for being here. If you have a question based on any of the points Jason's just raised, do feel free to write them in the chat box, and we can use those as discussion points for our discussion shortly. Now I'd like to hand over to Fozia Haider for her reflection on what's been said so far. Let me just introduce Fozia to you. Fozia worked as a regional peer researcher at the McPhin Foundation on the evaluation of a project called Women Side by Side. And she also led one of the projects, a women's organisation serving minority ethnic communities. She's recently founded a social enterprise due to her interest in reducing health inequalities and gaining better outcomes for disadvantaged communities and volunteers as a board member for Citizen Advice and research advisory group member for the Equality Trust. That's Fozia Haider. Are you there?
Hi, thank you, Phil. And thank you to Vanessa for inviting me today. It's been a pleasure listening to everybody, and some really powerful presentations. So, thank you to everyone. Just to reflect on what I've heard, I think as researchers, we have our own biases, and what these biases are is shaped by our own individual experience within society, but also by our circumstances. And these factors include gender, ethnicity, our socio-economic status, education, etc. The list goes on. But it's more than the individual experience. The history and current circumstances of our society shape our biases, our colonial past, endemic social inequalities, and of course, institutional racism embedded in organizations, which is fueled by the media and social media. These biases will unconsciously impact our research. So we all really need to recognize and acknowledge our biases, particularly those in leadership positions whose biases arguably implicate upon the research the most significantly. Really, this leads to, asking the question of who are the decision makers and how are they going to move forward? Because the present is a really good time at the moment, in my opinion. People of colour are being discussed. There is co-production, which is happening. Sadly, it's taken a pandemic to bring this to light, but we still have a long way to go. How, the decision makers are, the leaders of our society, of the organizations, our infrastructure organizations as well, especially the third sector, who have been absolutely phenomenal during the pandemic. So what I see, and from my experience, I've seen a lot of co-production happening in the past year, where the NHS, the third sector, with trusts and foundations are coming together to actually do, to actually address these inequalities, and to work out a way to really, get some balance. So it is a good time. I know that what we've discussed has been around, how it feels like a vicious circle, really, when you hear about racism and, the inequalities in health and everything else. How do we actually overcome that? So, as I said, we do have a long way to go, but the time is really right, and we should really seize the opportunity.
Brilliant. Thanks, Fawzia. That's great. I want to hand over now to Sandra Jayakody, who's a service user who started her journey in mental health research as a lived experience advisory panel member. She then continued to expand her involvement in research into physical health and is currently the lay chair for Imperial BRC Public Advisory Panel and the NIHR Applied Research Collaboration for North West London. Over to you, Sandra.
Hi, thank you everyone. Thank you so much for having me here today. I am just blown away. At the same time, I'm also feeling a bit vulnerable at the moment because when I heard Sarah Ahsan's poem, I felt like I was walking with her, walking in that poem because it resonated so much about my own life journey with being, labeling the illness and reaffirming medicalization. I just wanted to share with you something that I've been on antipsychotic drugs for 14 years, and I am 3 weeks clean now. So it is like moving away from being, to be labeled and able to take your own journey from there. It's a big move for me, so I could be a bit emotional today, so bear with me. I'm going through that withdrawal symptoms at the moment, okay? So, and the other thing, and what Tarek Younis said was for me, highlighting the psychology, I can't pronounce the word, psychologism around pre-criminal. This is something that I never would have thought about, and it never even occurred to me, but thank you for highlighting this. And it is something that, I feel sad to hear this, but I think we need to really address this. And if researchers think there is an area for research into this, I think we really need to look into that. And another song by Dr. Jason Arday, he mentioned the song, "No One Can See Me Cry." And I have experienced this in my working environment, not here, but in Malaysia, where I was the floor manager. And because it was predominantly Chinese and I was Indian, and so I felt the racism over there, and I would go into the toilet and actually cry, but I never reapplied my makeup because I wasn't wearing makeup at that time. So in every context and in all your presentations really resonated with me a lot. Now, I am not a researcher, but I have been on the other side of it, advising researchers on patient and public involvement in research. And what I have found is my observation was most of the researchers were predominantly white. I've never worked with one lead researcher who is from a BME community or from another community. They all have been white, and also the team themselves have been all white. They might be an occasional a team member who might be an Asian or a Black, but otherwise predominantly white. And when they call for patient and public involvement members, you would see that I would be sitting there as one Black, somebody from the BME community or one or two. And I was watching your previous videos, and I think one of the first person who spoke, she also mentioned about she's not the representative of the entire BME community or the Asian community or the Black community. So I am not a representative of the Asian community when researchers come to discuss about a research topic that is very related to an Asian or a Black ethnic minority group. So this to me was like, are we really doing research? Are we having the patients who are from the BME community as a tick box? I sometimes felt like I was sitting there because I need to tick that box. I didn't feel part of the team. So it's important that when you're doing that research, that there is inclusivity in the proper sense. The other thing was like, what needs to be changed? I think I have got a daughter. I think from my own experience, I decided to steer her into becoming a psychologist. So she's doing her degree in psychology. I definitely will ask her to watch all your YouTube videos on this session, because if she's going to become a researcher, I want her to be prepared in advance. And the fact that we do not have enough professionals from the BME community in terms of fulfilling the roles of psychologists or psychiatrists. I've seen a lot of people from the BME community as a service user in the from the nursing capacity. They are nursing or community nurses, but not higher than that. So this is an area that we need to fill up as well. So the NHS has to really look into actually employing more people from the BME community into these roles, or trying to, identify pathways for people to get into this kind of professions. Like when we are short of teachers, we will find a lot of advertisements out there for teachers. When there's a shortage of police, there'll be a lot of advertisements, but we never see this kind of recruitment into education or into the professions from the BME community. I think that needs to change as well. The other thing, what I think needs to, when he asked me to come on to this, only then I realized what I was actually missing when I was in these organizations doing the research. And I was thinking about it, and I said, that is when I started recalling, yes, there isn't much people from the BME community who are doing research about mental health itself, because even the research questions are not being asked they're not being asked to the right people. People who do the research is actually the interest that they have in the research that they want to do. It's not what the members of the public or people with a mental illness want a research topic to be, a research question to be asked. So there is another thing, this has to be included as well in terms of what research questions need to be asked. Where are we asking these questions? Who is it that's doing this research? Today, I looked at the website from one university, and I saw 2 research being conducted on mental health, where about more than 50% of the rest of the research were on physical health. So we need to do more and more research on mental health that is actually would address these issues of racism within mental health. Thank you.
Sandra, thank you very much. Congratulations for sharing. Thank you for sharing all of that with us, Sandra, and so pertinent that you say you've never worked with a lead BAME researcher through your work. Thank you both very much, and thank you all. We will now take some questions for Tarek and Jason, and if you want to make comments for Zia and Sandra, feel free. If you have a question that you would like to ask about any of the issues that have been raised tonight, do write that in the chat box, and we will try to get through as many as we can. I know we had Sanah here earlier, and I think Sanah wasn't planning to stay with us, but we do have a question here for Sanah, if you're still there, and if you feel like you'd be able to take a question from us.
Yeah, sure. No, I am. I'm still here. Thank you so much. Yeah, the presentations were incredible. So yeah, thank you. I'm happy to take the question.
Okay, thank you, Sanah. So the first question is about the medical model, and you were talking in your you were speaking earlier saying about the language of stories. So the question is, what is the language of stories? Shiari and Ghazals talk about mental state in a very different way to the medical model. So what is the language of stories?
I think that's Shairis, I think, and Ghazals. Yeah, amazing question. So that's referring really to Urdu poetry. And I think it really raises an incredibly important point about, you know, how the English language dominates us in every sense, and what that does. And I mean, if we're talking specifically in terms of research, how language really is a tool to maintain and reaffirm power, and how that works, especially through the English language, and often erases indigenous knowledge. You know, it erases our own language and our own systems of knowing how we feel. So I mean, I think, for example, if I just refer to specifically the Urdu language, we have terms like udas, which is really actually capturing sorrow and heavy-heartedness that doesn't fit within this biomedical framework, you know. And I think there is a lot in coming back to our own language and in that sense making of distress, and also being able to place that, most importantly, within what is happening around us. And I think just really reaffirming this point that what the medicalized language does and what this very individualized language, sorry, I've got my window open and there's a lot of noise in the background, so forgive me for that. I hope you can still hear me.
Yeah, sorry.
Yeah, no, I was just going to say that, you know, that what this very medicalized and individualized language does is it reaffirms this lie that distress belongs in our individual biochemical makeup, you know, and that we can actually address this through taking pills. And what that harmfully does is turns us away from what is happening around us and actually addressing the systemic and structural injustices that are causing our suffering. And, you know, Tarek made that point really well in terms of using Grenfell as an example of that, where the language of mental health is co-opted to actually perpetuate violence. And we can think, especially, I don't want to go on too much, but I just want to draw on some of the points that Tarek made, you know, in terms of racialization. When we bring in racialization into this language and how the medicalized language is used to oppress, we can think especially about, you know, schizophrenia and the stories of how medicalized language has been used to oppress Black people especially. So, you know, drapetomania, for example, which I mentioned in the poem, is a diagnosis that was given to Black people that were seeking liberation, right? And the face of schizophrenia especially was actually termed Negro schizophrenia in the 60s for Black men that were basically involved in the Detroit riots, you know, involved in the civil rights movement. And I think Tarek mentioned Malcolm X as well. You know, Malcolm X was apparently having symptoms of psychosis and schizophrenia himself, for seeking liberation as a Black Muslim, you know. So this language, this framework, which is affirmed through research, is incredibly harmful, basically. And I think it turns us away from what's happening to us to cause our distress. Sorry, that was a very long answer.
No, that was brilliant. Yeah, you raised really brilliant points there about the language, about different cultures, and about how those things interact. And I think those are really important things to raise. We have another question that's related to your talk, which feel free to comment on if you wish. So this was Sanah is right in questioning our stories in terms of, once we've spoken about our story, who does that narrative belong to? Does ownership stay with us as individuals, or do our stories, which may be different on different days, get appropriated by the researchers to be massaged to fit what the researcher's purpose is? It says, the person who's asked the question, it really worries me and makes me reluctant to say too much for fear of how it'll be interpreted or misinterpreted. Sanah, does that resonate with you at all, based on what you said?
Yeah, it's such an important point. And I think, I mean, there's lots of things that are coming up for me with this. It's making me think about someone who approached me recently, who, yeah, I mean, and I don't in any means, I'm not trying to bad other in any way in this sense, but I think, you know, I was approached recently about, you know, doing some research on queer Muslim stories, but the person who was wanting to tell those stories is a white male. And I asked the question, you know, what is it about these stories that makes it feel like you are the right person to tell those stories, and what's kind of interesting you in this? And I think for me, there was a real sense of discomfort. And it brings us back to the question, which was one of the points that I initially made, which is, who is telling these stories and why are they telling those stories, you know? And this is the really, really difficult thing that we are facing, that within our profession, what we have is a profession, I mean, I'm talking about clinical psychology here, but I think this sounds across a lot of the mental health professions, a profession that is 88% white, you know? So inevitably, the storytellers are predominantly white when it comes to who gets access to the research world and who gets access to those, to even tell the stories initially. So we have the problems that are deeply embedded and structural, right? But we also then we open up to, and I think what Tarek was saying earlier, which is just so heartbreaking, that the thin walls, when we assume confidentiality, actually these stories are being shared to really perpetuate systems of oppression, right? And I'm not sure that I can say where are safe spaces. I don't think that I'm able to say where are the safe spaces to tell these stories, when actually our own our own profession is complicit in this harm, and there is a lot of violence happening under the guise of care, you know. So yeah, I mean, I guess I'm just offering my own uncertainty and in that space, and just being with that, really.
Thank you. Thank you for that. And thank you for taking those questions and for staying with us this evening. Tarek, I wanted to turn our focus to yourself now. Are you there?
Yep, there's the button.
Hiya. So I was going to ask you about coercion, but I wondered if you had any other comments based on any of that at all, or you just would you like to talk about coercion because you mentioned that in your presentation?
Yeah, thank you for bringing that up. Actually, so I think I'm sort of struck by the dilution of the different roles that mental health professionals are increasingly playing. So mental health professionals are increasingly playing actually more and more different sort of roles according to the political climate. One of them is policing. We know that through hostile environment. We know that through prevent. You know, even right now with the war on knives, you know, public health sector workers, you know, are being asked to sort of identify and sort of refer individuals they suspect might become gang members, etc. So there's a whole there's so much to all of this that's already implicated. And then we have to think about, oh, so now, you know, if someone is referred to therapy through any sort of policing role, whatever it might be, you know, what is the impact of coercion in that therapeutic space? You know, that they have to potentially game the system to, you know, to actually get by and do what they have to do. I think there's an element of coercion, I think, in the dilution of mental health professionals' roles that I think we tend to see our roles as autonomous and very sacred. But in fact, you know, we're a microcosm of a wider structure. And I think there's something there that has to be taken into consideration. There's also the coercion of mental health professionals. So I just spoke recently to a mental health professional who, for example, felt like they had to do a prevent referral for a racialized Muslim. And, you know, they're sort of explaining and justifying it. But, you know, as I've spoken to many of these people before, one of the reasons we sort of come down to is why they made that referral was the fear of repercussions of what might happen to them if they don't make the referral, right? Imagine they find whatever it might be, a racialized Muslim youth, racialized Black youth, anyone that they suspect might commit, you know, that they have that gut feeling, right, that they might commit a crime. There's this sort of very pronounced insidious element of surveillance, even on mental health professionals, to play their part. For fear of what might happen to them if they don't abide by the regulations and sort of the political climate around them. So there's a lot about coercion, that the subtlety of coercion. You know, I think I'll just end on one study I found is always striking to me. In one of the states in the United States, at one point, when it comes to stop and search for the police, the police were able to do stop and search without having to ask if the youth that they were stopping consented. At one point they did. And what was really fascinating, Michelle Alexander explains this in her book, The New Jim Crow. They found that even though when the police started asking, do you consent to the stop and search we're about to do, they found that, hey, all the youth consented to it. You know, and the reason for it is pretty simple, because you just never say no to securitized space, right? If there's a securitized space, police officer, whatever it might be, you just don't say no because of how suspicious that might be. Now we have an untold number of mental health professionals involved in security space, whatever it might be. And we've yet to really understand the ramifications of that.
Thank you. Yeah, that's really covered all those different points about coercion. Now, I wanted to ask you as well, you made a point in your presentation about every decision that's made in mental health being a political act. And I wondered if you could just talk a little bit more about that, because I think that's really important.
I think it's really the inverse. I think there's something about, so it was Philip Cushman. He was the author of the book I was thinking about earlier. There's something about psychology, or the disciplines, the side disciplines themselves, which hold this very positivist, universalist, apolitical veneer. That there's sort of, we're at the heart of the psyche, the psychological configuration. We're not really interested in politics. And I think there's an argument there that's already been made, repeatedly, that no, the side disciplines are purveyors within a political space, right? So our understanding of normality, abnormality, our understanding of what's reasonable, unreasonable, rationality, irrationality, all these things are managed through the side disciplines. And so every decision that's sort of made in terms of research, in terms of be it in mental health sort of interventions, or even maybe sort of whatever, social psychology, whatever it might be, they all belong within a very politicized space. And I think that's one of the things that I find very fascinating. Even if we look at Israel-Palestine, and I think I'll bring that up right now. Someone brought up to me that, they went to see a mental health professional who just simply didn't have an opinion. They were sort of just, they didn't, they were either side. They were sort of middle grounding the Israel-Palestine issue. But for them, Israel-Palestine is dealing with a settler colonial state on the one hand and occupied, population on the other. And so this element of middle grounding of the centricism that comes, I think, in the side disciplines requires a lot of reflexivity. What is actually the political leanings of psychologists? And I would love more research on that, to be honest. I'd like to know more, on that sort of reflexivity. How do psychologists actually position themselves in the political climate that we're in?
Great, and final comment, I wonder if we can also ask Jason the same question about this. Given the importance of the side disciplines and that research and the implications of that, how much of the teaching that goes on is from a critical lens?
Yeah, I mean, I guess the question is that the absence of a critical lens is what currently ensues, right? So I think that critical lens means, to draw on what everyone has said, it does involve having the necessary people in the room. I think often there's an extraction of minerals that is quite distasteful, exploitative and problematic. And, I think it's about thinking in terms of the psychology profession, how do we actually open up spaces for more Black and ethnic minority people? I think, white psychologists also need to engage in continuous forms of, as Tarek said, reflexivity, but more importantly, their own questioning and challenging their own values and belief systems that are particularly doctored towards a particularly dominant Western form of psychology, because increasingly what we do know is that those forms have never worked for Black and ethnic minority people. And if anything, they all reside in a colonial hangover, or they're a weapon of subordination for Black and ethnic minority people. So as Sanah said, it's often been a weapon of kind of the Negro psychosis, for example. And it's that kind of framing that we kind of need to move away from, because really it's almost, it pans to Malcolm X's famous quote when he said that racism is like a Cadillac, a new model comes out every year. If you think about psychology, the way we frame Black and ethnic minority people through psychosis, there's a new way of doing it intergenerationally and intermittently, and it kind of happens with alarming irregularity. And more often than not, if always, these constructs are designed by white psychologists. So, I do think that criticality does need to reside in a challenging and disrupting of values and belief systems at the iterative stage of a psychologist's development. It's not to say that that can't be done post gaining a qualification, but I do think that the time where you're going to have the biggest imprint is during training, and then I think there needs to be continual training to supplement that learning and to continuously challenge that cycle of whiteness, which I think can be inherent in a lot of psychologists' practices.
Great, and that sort of leads us on to the next question. And obviously the theme for this evening is the question, what needs to change? So the question is, do you think a reset mindset can be adjusted with education and community-based projects?
Yes, the short answer to that is yes. I think it, I hate the J word in terms of a journey, but I guess we're all at different stages. And, what Black and ethnic minority people have been able to demonstrate since time immemorial is tolerance and patience. And if ever there was tolerance and patience to be needed, it's now, whilst people immerse themselves on that journey. And I think that training and education is our best instrument, but to do that, people do need to get comfortable with the uncomfortable. And a lot of that is kind of unlearning what has been learned, because that unlearning of what has been learned, that learning has always operated or disrupted the progress of Black and ethnic minority people. So it's unlearning those as kind of constructs of learning and constructs of psychological well-being, and really moving towards a model that benefits not all people, because it's not just for the benefit of Black and ethnic minority people to be able to gain the mental health intervention they need. It's also advantageous for white people who, in terms of being more culturally cognizant, more racially literate, and from a psychology point of view, understanding the nuances of racism and how it penetrates all of these kind of layers. I think that's really, really important. So, there's work to be done, and I think education will always be, across any discipline or mode of thought or mode of kind of knowledge transfer, will always be our best attribute and our best asset towards mobilizing the change that we all want to see.
Great, thanks, Jason and Tarek. A similar question to you, I guess. What needs to change? Do you think a reset mindset can be adjusted with education and with community-based projects? We've also had tonight the suggestion of completely different methods, using arts and the creative matter as well. Do you have any thoughts on that, Tarek?
Yeah, I agree with everything Jason said. I think Jason also made a really important point when he spoke earlier about the fear that racialized minorities have. That's a fear that's very, very pronounced. I think it's increasingly pronounced. And I know Professor Frank Keating is in the audience. He's written about that, years ago. I think there's something about, in terms of community response, first and foremost, that's very necessary given the fear, right? I don't think the fear is something that we could just promise, oh, by the way, we've educated the staff to think differently. I think there's a validation of that fear that's not being acknowledged. And that fear is getting worse and worse. And I think there's something about the emphasis on cultural competence, et cetera. I think there was a question about sort of political competency. And, a very striking thing that's been happening, I think, as people know more about me, I'm obviously very politically opinionated, so to speak. So I think people know, oh, I can come to Tarek and talk about these issues. And I think we've come to a point whereby I think what I find is really interesting, we're trying to develop this cultural sensitivity, this training for people, but there's an element of political competency that's actually really quite necessary. I mean, I've had even people come to me for fear of prevent referral, and they're not even Muslims. They just want to be able to share sort of their political thoughts on certain issues, whatever it might be. So I think there's an element here whereby this idea of safe space really has to be taken seriously, and I think there's examples of that in the history of the global North that we can emulate. So I just wanted to really just pull out that point that Jason was saying. I'll just say that I think there's only one limitation to training. I think there is a neoliberal ideal of training that is really quite significant that we need to just mention. I think there is sort of the way I think the sort of bureaucratic systems are constructed in healthcare is that there is a very sort of top-down, we can train all our issues away type of mentality. I think good training can can definitely make a very big difference. I just think there's definitely a lucrative industry or market for training that we have to be also aware of, but that's it.
Brilliant. Tarek, thank you. And thank you to all of our speakers tonight. As we draw the series to a close, I want to pass over to Vanessa, who is part of our organising committee. Vanessa, over to you.
Sorry, everybody. Let me just try and... Okay, I just wanted to thank everybody. Actually, it's so hard, really, to know how to end this webinar tonight. And also the series. We've run 6 webinars, 1 a month for the last 6 months, and tonight's been extremely powerful, thought-provoking, grounding. And actually, we've put together some Menti polls. So I'm just going to go through a few slides to thank a few people, but Jessie's going to put in the chat 3 poll questions, and actually the first is a word clouds of words, and so we've probably had some inspiration tonight for what we might want to put in there. I just want to acknowledge how hard it is sometimes to be in these kind of spaces, and several people have talked about the importance of safe spaces, and it's been our aim through this webinar series to try and create a learning space. I really want to thank everybody for being here tonight and for participating with us through. I know many of you have been to all of our 6 in the series, so it's just a huge shout out to everybody that's participated. And obviously this didn't happen without the massive commitment and incredible inspiration and the personal sharing of knowledge. Whether that's from lived experience, expertise, or whether it's through academic study, whether it's practitioner based. One of the things we tried to do in the series was bring together people who were at the beginning of their career and towards the end of their career, that were part of organisations or that were freelance. We tried to think about bringing together a mix of people, and I've written on the slide lots of names, and I thank each and every one of you for taking part. It's been a privilege to work with you over the last 6 months. We also need to say a huge thank you to the people who have helped organise the series. Most importantly, Will, who has chaired us every session, is just about to go off and do his medical exam. So wish you a huge, great shout out for that, Will. Good luck with your forthcoming exams, and it's been a privilege to work with you on this series. Alison and Jess have managed our chat. Andre's always been on the live feed and helped us to shape all the events. And Suman, Frank, Colin and Harry have also been with us on this journey, supporting the whole programme. And as I said, thank you so much to everybody for being present, for contributing in the chat, for being thoughtful and being respectful throughout. I just wanted to say something about where next. I mean, there is no way to end. We were trying to think about how we could kind of bring stuff together. So we're committed to trying to bring a resource together. So across the 6 webinars, we're really going to try and bring some learning together from that. And I'm in touch with a couple of people that are going to help with that. And if anybody else wants to get involved, please do contact me, because we're really keen to make this a collective effort. We're going to host a skills workshop on Friday the 25th of June, and we'll send everybody an invite. It's Harry Sewell is going to host it, and it's very much about a skills workshop, because we've talked a lot about the things that are wrong with the system and the issues that we need to address if we're thinking about how to become an anti-racist mental health researcher. And each and every one of us are at different stages, if we say, of that word, the journey. So we wanted to kind of provide something which was here are a few things that we might need to learn along the way. So Harry's going to run a skills workshop, and everybody is very welcome to that in a couple of weeks' time. The webinars remain online. We hope to produce some more blogs around the series. So if anybody wants to write a blog and reflect on learning from this series, then please, again, step forward. And some people have suggested that we might want to set up a network. And if everybody wanted to host that network or wanted to link in with work they're already doing to keep these conversations going, then, do get in contact. This work continues, and I just want to say thank you so much for spending this summer evening with us. And I think, Will, you've got a word cloud maybe for us.
Yeah, that's right. So the things that were just shared on the word cloud, I can share that now. So just final thoughts there. So just let me know if you can see that. Can you see that there?
Yeah.
Brilliant. So I'll just leave that up on screen. Yeah, so thank you all. Thank you, Vanessa, and thank you everyone who's been mentioned for being involved. I know we've overrun a little bit, but yeah, thank you to everyone who's been here. When we first decided to host a webinar in June 2020, we were shocked by the statistics which showed the health inequalities in mental health and in psychiatry. Through the webinar in June 2020 and throughout this series of webinars in 2021, the reality behind those figures has really taken shape. We've learned so much from our speakers and so grateful for each and every one for sharing their experiences in what can be a really difficult space. As you said, Vanessa, the resources produced from the series are available to rewatch on our website and to share with your friends and colleagues. And I know you guys are going to be working to put those to further use in the future. And yeah, we look forward to seeing you on the 25th of June for a special training session with Harry Sewell, which will take place on 1 year on for the original webinar we hosted in June 2020, where Harry was our first speaker. Thank you to everyone again for being part of today's discussion, both on Zoom and those watching via the live screen. And a very special thank you to all for their thoughts and comments this evening. Thank you all once again for taking part, and yeah, we hope to see you all again on the Friday the 25th, and thank you all very much.